Bismillahirrahmanirrahim. Every day we meet cases that motivate us to search and read more. And we will present some of these cases today, inshallah. Cases with a swollen face, hands, and feet are frequently presented to rheumatology and immunology clinic. Some of these cases are so simple and straightforward. For example, female patient aged 55 years with hand and knee pain, ESR and CRP are within normal, rheumatoid factor is negative, so this is simply a case of hand osteoarthritis. Another case of female patient aged 38 years with polyarthritis, ESR 60, CRP 24, positive rheumatoid factor and NCCB. And in this case can be diagnosed as a case of rheumatoid arthritis. Also, if we find a case of swollen hands or puffy fingers presented with polyarthralgia, Raynaud's phenomena, antinuclear antibody, we will do capillaroscopy for the patient and we will find that there is some giant capillaries, there is a mild decrease in capillary density. This can be, we can say that this is early scleroderma pattern. So we ask for anti-U1RNB. If it is positive, so we can diagnose the case as a case of mixed connective tissue disease. Another case also presented with puffy hand, Raynaud's phenomena, positive antinuclear antibody, and capillaroscopy revealed giant capillaries, marked decrease in capillary architecture with some areas of hemorrhage. Anti-scleroderma 70 is positive, so this case can be diagnosed as a case of early scleroderma. But not all cases are that simple. Some cases are challenging and motivate us to search more to reach the diagnosis. We will know about this in the next slides, inshallah. Our first case is for female patient aged 16 years, presented to us with 2-month history of fever, lower limb edema, skin rash, polyarthritis. One day before admission, the patient developed swelling of both eyelids and lips. Patient was admitted to Mansoura Rheumatology Immunology Unit, and on the day of the admission, the patient developed stridor and was intubated. This is the photos of the patient. As you can see that there is angioedema affecting the eyelids and the lips, and the patient was intubated. This is the skin rash affecting the upper limbs and lower limbs. Investigations revealed CBC showed anemia, neurostenochromic, and mild thrombocytopenia. Creatinine was high, 1.7 milligram per deciliter. Urine analysis showing proteinuria and hematuria. ESR was 80, CRP was 4.8. Antinuclear antibody was positive to 7 folds. Anti-double-stranded DNA was positive, it was 8 folds. C3 and C4 were consumed. As we can find, this is a case of lupus with angioedema. Angioedema can be classified into 2 major groups: mast cell mediated, which is associated with urticaria, wheezing, and usually occur after exposure to identifiable trigger. And also we have the kinine mediated, which occur mostly in the absence of a specific trigger and without clinical signs of mast cell degranulation. Hereditary C1 inhibitor deficiency, which is the most well-known type of kinine mediated angioedema, usually occur in healthy individuals without underlying disease, strong family history, and usually present earlier in life. Acquired type of C1 inhibitor deficiency resulted from autoantibody or enhanced catabolism of C1 inhibitor, and mostly reported in patients with autoimmune disease or lymphoproliferative disorder, and usually occur in adulthood with absence of family history. This is an example of patient with acquired angioedema associated with lymphoproliferative disorder and eosinophilia. Angioedema can occur in lupus. Life-threatening angioedema requiring mechanical ventilation has been reported before in lupus patients. It may present as a single episode or may remit and relapse in association with or independent of lupus flares. Severe respiratory tract infection has been reported to be a precipitating factor. Hereditary angioedema may be seen in lupus patients. Acquired angioedema in lupus is rare. Acquired angioedema in association with lupus occurs with classical pathway. It's classical pathway mediated associated with hypocomplementemia, transient low C1 inhibitor, antigenic and functional level, absence of C1 inhibitor autoantibodies and lymphoproliferative disorder, resolution of angioedema with immune suppressive therapy was associated with normalization of C3, C4, C1 inhibitor levels. Our patient was treated with pulse steroid, and the angioedema improved, and the patient was extubated. The next case, case number 2, is for a female patient aged 38 years, presented to the ER with progressive dyspnea and orthopnea. Patient has history of recurrent chest infection. Patient was discovered to have precardial effusion and was admitted at cardiology department. Pericardiocentesis was done. Pericardial fluid analysis revealed that it was exudate. Patient has puffy face, hands, and feet, and the patient was referred to rheumatology and immunology clinic for evaluation. Upon examination, the patient had puffy hands, face, and feet. Patient also has non-pitting edema of hands and lower limbs with dystrophic nails, as we can see in the photos. Investigations of the patient's creatinine, urinalysis, albumin, TSH all were normal. Antinuclear antibody, anti-double-stranded DNA, ANCA, C3 and C4, lupus anticoagulant, or the autoimmune profile also was normal. Pericardial fluid analysis, the biochemical analysis revealed that it was exudate. Protein was 4.6 gram per deciliter, glucose was 451 milligram per deciliter, LDH was 1,085 units per liter. Microscopic examination, the white blood cell count was 2,700. Cytology revealed reactive hemorrhagic smear. Culture revealed no growth, and ADA was negative. What do you think the diagnosis of this case? It's a case of yellow nail syndrome, which is a very rare syndrome characterized by triad of yellow nail discoloration, pulmonary manifestation in the form of pleural effusion, bronchiectasis, or recurrent pneumonia, lymphedema, which appear in the form of swelling of lower limbs, and this commonly face and hands. Etiology is unknown, but may be related to impaired lymphatic drainage. Most of cases are isolated, but rare cases are associated with autoimmune diseases or malignancy. This is a case report of yellow nail syndrome associated with precardial effusion, as was found in our case. Case number 3 is for a female patient aged 23 years, presented with left hand pain and swelling. Patient has history of similar condition in the right hand 1 year ago, with no improvement on antibiotic treatment, and surgical treatment was done for the patient. Patient was referred to rheumatology and immunology clinic for evaluation. Patient has history of IV line insertion in her left upper limb. Upon examination, the patient, the right hand was swollen and tender, swollen and edematous with sensation. On the other hand, there is scars of the previous surgical treatment. Musculoskeletal ultrasound was done for the patient and revealed mild subcutaneous edema in the dorsum of the hand associated with some gas hookup. What's the diagnosis of this case? Simply, it's a case of benign surgical emphysema. Benign subcutaneous emphysema of non-infectious etiology has been documented in several case reports. Correct diagnosis will avoid unnecessary surgical exploration for a benign condition, not associated with other symptoms, and the patient is systemically well. It has been reported as a result of high-pressure injury from power tools, minor puncture wounds, creating a one-way mechanism, air gun injury, and surgical procedures to the hand. And crepitus is frequently felt in these cases. Case number 4. It's about male patient, aged 50 years, working as a fisherman, presented to us with left hand pain and swelling 3 months ago. No other joint manifestations. Patient was diagnosed as rheumatoid arthritis and received methotrexate without improvement. Patient has history of fishbone injury 4 months ago. Examination of the patient revealed that there was swelling over the wrist joint and the dorsum of the hand. Also, swelling over the tendons and the metacarpophalangeal joints. We can note also here that there is swelling over the ulnar side of the wrist joint, also swelling over the flexor tendon, and there was a limitation of the flexion of the fingers. Our patient was 7, RB was 8, CBC was normal, and NCCB were negative. X-ray hand showed no erosion and no joint space narrowing. musculoskeletal ultrasound showing tenosynovitis of the adductor pollicis longus, extensor pollicis brevis, extensor digitorum, and extensor curvi ulnaris, with extensive synovial proliferation, as we can in the photos. Tenosynovitis also was noted in the flexor tendons with no significant synovitis. So we are in front of a case of tenosynovitis. Causes of tenosynovitis, after revision of causes of tenosynovitis, we can find that it may be autoimmune causes, but our patient had no systemic manifestations suggestive of autoimmune disease. Also, the serology of the patient, the autoimmune profile, was negative. What about the overuse? However, the ultrasound of the patient showing extensive synovial proliferation, which is not very typical to overuse tenosynovitis. So we think about infective tenosynovitis. Any organism can cause tendon sheath tenosynovitis. Infection may occur after trauma or hematologenous spread. Pyogenic tenosynovitis usually caused by gram-positive organisms. Trauma-related to tenosynovitis can occur with cat and dog bite leading to polymicrobial tenosynovitis, puncture wound by thorns of wood plants leading to fungal tenosynovitis, IV drug use, or fresh or salt water-related marinum tenosynovitis, as in our case. Our case has history of fish bone injury. Mycobacterial marinum is the non-TB mycobacteria responsible for tendon and tendon incubation period range from 6. Key elements of diagnosis including high index of suspicion, negative bacterial culture, history of tissue biopsy and culture, treatment with prolonged course of antibiotic, treatment with or without debridement. The next group of cases are a group of cases in which the diagnosis was delayed because something was overlooked. Case number 5 is for a female patient, aged 38 years. Patient is SLE 10 years ago. Patient has history of lupus nephritis and received MMF for a long duration. Patient presented to us with left knee pain and swelling 3 months ago. Arthroscope and drainage was done 1 month ago without improvement. Upon examination, there was left knee effusion and tenderness, left lower limb edema and tenderness. Investigations were done. CBC was showing pancytopenia. Creatinine was 1.5 milligram per deciliter. ESR is 65. CRB 96. Anti-double strand DNA was negative. C3 and C4 were consumed. Urinalysis revealed pus cells more than 100 and protein 1 plus. Uric acid was 5 milligram per deciliter. Duplex left lower limb was showed patent deep venous system. Musculoskeletal ultrasound revealed moderate knee effusion. Abdominal ultrasound revealed left renal cortical collection with internal echoes, likely renal abscess. Synovial fluid analysis, the white blood cell count was 30,000. Culture revealed no graft. MRI of the left knee showed osteonecrosis with cystic erosion, degenerated posterior horn of both menisci, moderate effusion, and Baker cyst. What do you think the overlooked thing in this case? I think it's the TB. Synovial Nelson was done and it was positive. So we are in front of a case of TB arthritis. Symptoms of tuberculosis could be atypical and non-specific, especially in immune-suppressed patients. SLE patients have higher prevalence of TB than the general population. SLE patients have increased risk for extrapulmonary TB. Predisposing factor for TB in SLE patients, including high SLE activity and particularly active lupus nephritis, corticosteroid treatment, and the use of immune-suppressive drugs. Osteoarticular TB is a rare form of extrapulmonary TB and accounts for 1 to 3% of all TB cases. Sites of involvement including the spine, long bones, and less commonly the peripheral joints, usually presenting as chronic monoarthritis. Diagnosing osteoarticular TB is often challenging due to non-specific features and insidious onset and diagnostic delays frequent. The long-term outcome with prolonged course of anti-TB therapy with or without surgical intervention is generally good, but relapse is well described. Case number 6 and the last case. was for male patient, ages 70 years, ex-smoker 3 years ago, diabetic, hypertensive, ischemic heart disease, which angio and stent was done around 3 months ago. Patient was presented to us with 1 month history of bluish discoloration and ration both lower limbs and buttocks. This is followed by gangrene in toes of both lower limbs with some areas of ulceration and necrosis. Patient was diagnosed as having vasculitis outside and received corticosteroid treatment without improvement. This examination of the patient, there is the bluish discoloration and the gangrene of the toes. We can note the ulcers with necrotic areas and the lower limbs. Investigation, CBC was normal, creatinine was 1.5, urinalysis showing protein was nil, pus was 20 to 30, RBCs was 10 to 15, liver function was normal, ESR was 90, CRB was 69, and virology was negative. Autoimmune profile in form of anti-nuclear antibody, rheumatoid factor, T3, C4, ANCA, lupus anticoagulant, anticardiolipin, IgG, and IgM all were negative. Duplex on both lower limbs was done and showed patent arterial system with some atherosclerotic areas. Renal ultrasound and duplex revealed aortic aneurysm with atherosclerotic plaques. So what's the diagnosis of this case? Simply, it's a case of cholesterol embolization syndrome. It's type of embolism resulting from fracture of an atherosclerotic plaques. Should be suspected in patients who develop worsening renal function, hypertension, distal ischemia, or acute multi-system dysfunction. May occur after an invasive arterial procedure or spontaneously. Key components of cholesterol embolization syndrome include proximal large caliber arterial plaque, plaque rupture with embolization of the breast, mechanical occlusion of small arteries, intense foreign body inflammation, and organ damage from mechanical obstruction and inflammatory vascular changes. And thank you.